The objectives for the next hour are going to be learning the assessment of microscopic and macroscopic hematuria, which will include urine cultures, urine protein creatinine ratios, urine calcium creatinine ratios, and imaging of the kidneys. Evaluation of proteinuria will be discussed with learning the differential diagnoses of proteinuria, and we'll discuss the pathophysiology of nephrotic syndrome. And then hematuria and proteinuria, when they come together, we'll learn that they have a worse prognosis than either one of those alone, and that post-infectious glomerulonephritis and IgA nephropathy are the most common causes of pediatric GN. And so starting with hematuria, and I want to emphasize for the purpose of this discussion, we're not talking about myoglobinuria or hemoglobinuria or food or drug or dyes that change the dipstick. We're talking about true hematuria. And it's a little clinical pearl that as little as 1 ml of blood in a liter of urine is enough to induce a visible color change. So it's really a pretty wide spectrum between microscopic and macroscopic hematuria, and more or less the evaluation between both of those is going to be the same, although the patient's awareness of the original problem is going to be different. And as you're trying to figure out what to do with a patient who comes in complaining about macroscopic hematuria, or that you've discovered microscopic hematuria through urine analysis, you want to figure out, is it an isolated or a complicated finding? Is the patient symptomatic? And is there a need to intervene urgently? So starting with macroscopic hematuria, when you first have the patient who comes in complaining about blood in their urine, you want to figure out what are the associated complaints and physical findings that the patient has. Commonly, if someone has dysuria, urgency, or frequency, you're going to think about infection, and of course you're going to do a urine analysis and urine culture. If they have flank pain that's radiating to the groin, you may think about infection or pyelonephritis, but you may also think about stones and nephrolithiasis or ureteral stones, in which case, in addition to the urine analysis and urine culture, you're also wanting to send a random urine sample for calcium and creatinine measurements. And to quantify urine calcium in a random sample, it's a screening test. You measure your calcium and your creatinine, and the normal calcium to creatinine ratio is less than 0.2 when they're measured in the same units. So it would be calcium in milligrams per deciliter and creatinine in milligrams per deciliter. If the ratio is greater than 2, then double check your units, because different labs will give you different values, and you can't assume that one carries over to the other. And if it's elevated, you may want to repeat it once or twice, or obtain a 24-hour urine collection for a more accurate quantification of calcium excretion. And this is just a little picture of what calcium oxalate crystals might look like under the microscope in a urine sediment. And these are probably the most common crystals that you'll come across. If the patient has flank pain and radiating groin pain, and you're thinking that it's a ureteral stone, then you also probably want to do blood, maybe for Chem7 to see what the renal function is, and a CBC to see if there's signs of infection. But more importantly, you want to do imaging. And in pediatrics, we very often will first do a renal ultrasound to see if there's any obstruction of the ureter and subsequent hydronephrosis. And you might consider a stone protocol CT that is done without IV contrast, because the calcium stone will show up on the CAT scan, but its presence can be obscured if you give contrast. So even if you're not sure that you're looking for a stone and you want a CT to explore other intra-abdominal processes, I would suggest getting a non-contrast CT first, and if that's negative, proceeding with IV contrast. And so the management of macroscopic hematuria caused by acute pain and a stone obstructing depends partly on the size of the stone. If it's large, it's not going to pass spontaneously. If it's small, you can try medical management. It usually gets stuck at the junction between the ureter and the bladder. And the management is going to be hydration, hydration, hydration. It's going to be pain control. It's going to be antiemetics. Some people use antibiotics. Some people use smooth muscle relaxants to get the stone to pass through that ureteral vesicular junction. And sometimes anti-inflammatories could be used if the stone's been there a while and obstructing. Okay, so moving on. Macroscopic hematuria, infection, stones. Other associated complaints a patient might show up with would be fever, systemic complaints, myalgias, arthralgias, maybe a rash. And this time you're starting to think of something more systemic, a glomerulonephritis and interstitial nephritis that has more systemic effects as well. And associated with those, you may want to screen for hypertension, you may want to examine for edema. And we'll come back to glomerulonephritis at the end of the talk. The other thing when you're trying to evaluate hematuria, in addition to the complaints of the patient, is just the general personal history of the patient, the family history of the personal history of the patient, and what's going on in the family medical history. For example, is this the first time the patient has had macroscopic hematuria, or has there been previous episodes? Has there been an antecedent infection? Did they have a pharyngitis 2 weeks ago, and now they have a post-infectious glomerulonephritis presenting? Or perhaps they've had a new medication on board, or a new cosmetic or toiletry or something that's giving them some sort of allergic reaction that can be acute interstitial nephritis. In addition, things that can cause macroscopic hematuria are going to be strenuous exercise and trauma. Trauma, of course, like a motor vehicle accident or an obvious sports injury, but exercise itself can give macroscopic hematuria. And there's different kinds of exercise-associated hematuria. There's the exercise-induced hematuria, which is primarily glomerular in origin, and that is associated with endurance, long-term exercising, such as running, rowing, swimming, spinning. It tends to present after the exercise has been completed or has gone on for a while, and it does go away after rest for several hours, if not days. The diagnosis of exercise-induced hematuria is one of exclusion, so you have to address other things first, and it's generally thought to be benign without any poor prognostic indicators in the long run. There's also exercise-associated trauma, which is not actually glomerular blood leak, but is lower down in the collecting system. And in some cases, this is going to be obvious trauma, renal contusions in contact sports. And then apparently you can get bladder contusions that cause hematuria, especially in marathon runners and also in bicycle marathons. And then there's something called exercise-associated hematuria, which is not necessarily actual hematuria, but might be hemolysis in the body, then the hemoglobinuria is passed into the urine. Foot strike hemolysis has been described in long-distance runners, so they have hemoglobinuria. And then there are patients who have underlying genetic disorders of metabolism, McArdle's, which is myophosphorylase deficiency, CPT2, which is carnitine palmitoyl transferase 2 deficiency, or VLCAD, very long-chain acyl coenzyme A dehydrogenase deficiency. When these patients are exposed to increased activity or increased strenuous situations, they develop mild rhabdomyolysis in some cases and severe in others, and that myoglobinuria can give you what looks like hematuria on dipstick, but it can also actually be nephrotoxic and result in acute kidney injury, which then, of course, spirals into hematuria and proteinuria itself. Okay, so that's the exercise. Other kinds of traumas that aren't necessarily obvious but sort of fall into the category might be something, renal vein thrombosis is something that gives gross hematuria in the neonate particularly. There's an anatomic variation of the large vessel structure called nutcracker syndrome, where the left renal vein gets compressed between the aorta and the proximal SMA. And during that compression, you can have pain, flank pain, and you can have episodes of hematuria. And then, of course, tumors can give you the trauma that will lead to hematuria. And the most common tumor in children is going to be Wilms tumor, except perhaps in the infancy when you might have more neuroblastoma. Urolithiasis and renal disease can be histories in the patient or in the family that are relevant to the analysis of new onset hematuria, and then screening for things or asking about things like bleeding disorders, hemophilia, hemoglobin S trait, in addition to sickle cell disease, can give you macroscopic hematuria. And deafness is something we always screen for because of its association with Alport syndrome. So we've run through this list, and in some of the cases we've thought the most common things, we have infection, we have stones, we have nephritides, you can have acute interstitial nephritis, and you can have a tumor. And then 2 points I want to make is the microscopic or macroscopic hematuria are more or less the same. But if we really focus down and say hematuria alone without proteinuria, then we get rid of some of these. And in that case, we're really looking at infections, stones, and tumors. If you're convinced that a patient has an infection, and the urine culture is negative, one of the little clinical pearls is to consider adenovirus infection because that's associated with hemorrhagic cystitis. And then the other bit is that even if you're not suspecting a tumor, unless you're sure you have an infection, I suggest that a renal ultrasound is non-invasive and it's very easy, and you can answer several questions all at once, including the fact whether there is a tumor or not, whether the renal anatomy is generally normal, and if there's any signs of stones. So another way to think about hematuria when a patient comes to your office complaining about it is to ask, where is the blood coming from, and particularly what's actually bleeding? Is it the kidney? Is it the glomeruli in the kidney or the tubules? Or is it further downstream? Is it the collecting system, the renal pelvis, the ureter, the bladder, or even the urethra? And the color of the urine may sometimes help distinguish glomerular from extraglomerular bleeding. If your urine color is brown, dark tea, Coca-Cola color, it tends to be a glomerular source. In addition, the urine analysis with a glomerular source of bleeding is usually going to show proteinuria, and it's usually going to show casts. In contrast, if it's bright red, it's more likely to be upper tract or lower tract than glomerular, and if it's red with clots, it's likely to be lower urinary tract, probably bladder or urethra. And then if it's only partial stream hematuria, then it's most likely to be urethra. And so what is partial stream hematuria? This is if you have a child or a patient who comes into your office. Sometimes they can give you a very clear history. There's blood at the beginning of the stream or blood at the end of the stream, but that not throughout the whole thing. But you can also have them pee into 2 cups, begin the void into cup number 1 and complete it into cup number 2. And with your urine dip here, this is the square for blood. In this case, the child had yellow turning green, showing the presence of heme in the first sample, but not in the second. And this was a continuous void, so he had partial stream hematuria. And in boys, in adolescent age, there's something called idiopathic urethrorasia, which happens in late school age, early adolescence, and it's bleeding from the urethra, from the bulbar urethra, and it's intermittent, it's benign, it's self-limiting, it can happen only once, it can recur a couple times in the course of a year or 2, and then it goes away. That too is a diagnosis of exclusion, and you do nothing about it, but it's something good to know about if you're seeing boys in your practice. And then since we have the dipstick sitting here, I wanted to point out that the detection of heme, the color change from yellow to green, is detection based on peroxidase activity. And with dipsticks, there's many reasons for false positive color changes in addition to the presence of heme, because many different substances have peroxidase activity. But by and large, if you have a negative dipstick that's negative for heme, you're reliably excluding the presence of hematuria unless for some reason you have super high levels of vitamin C in the sample, which would be fairly unusual. The other way it could be a false negative is if the stick is expired. Okay. The most common cause of persistent asymptomatic hematuria, and this would be microscopic hematuria, and we're talking persistent beyond 6 months duration, asymptomatic, no associated lab abnormalities, no hypertension, no imaging problems, nothing. The patient is fine and doesn't even know that the blood is there, except that you've detected it in the urine analysis. The causes that are common are hypercalciuria, which is increased calcium in the urine, and a couple of glomerulopathies, the most common of those being IgA nephropathy and thin basement membrane disease. And we'll discuss both of these a little bit. IgA nephropathy later, and thin basement membrane disease now. There was a time that thin basement membrane disease was referred to as benign familial hematuria, and it really had that was the description of it. It was benign, it tended to run in families, and there was blood in the urine, again, with no prognostic implications. And what we've learned since is that most of the benign familial hematuria is related to variations in the genes encoding thin basement membrane factors. The glomerular basement membrane is made up of collagens, and it's primarily type 4 collagens. And all collagens throughout the body are assembled from any number of different alpha chain monomers. And the type 4 collagens in the GBM are assembled specifically from collagen 4A3, 4, and 5. And the way the assembly works, here's Col4A3, 4, and 5, represented briefly, schematically, in a couple different colors here. They assemble, and then they curl or coil or braid, and they have different globular sections at their head and their tail, and you have head-to-head associations and tail-to-tail associations that form your collagen network. And the Col4A5 is encoded by a gene on the X chromosome. And so you only have one copy if you're a boy. And if it's an inactivating mutation, then you have something that's called Alport's disease, which is a progressive glomerulopathy that winds up with kidney failure and end-stage renal disease, and you need transplant. However, if you have a variation in your Col4A3 or Col4A4 genes, which are autosomal, then you only have a single copy mutation, and that's when you have thin basement membrane disease. And so it is meant to be a situation where you have abnormal anatomy or abnormal structure of one of the molecules, the 3, 4, or 5, and then the network is not fully assembled properly, and so the thin basement membrane is slightly distorted, and you have resulting hematuria. So if you have a single copy of Col4A3 or Col4A4, a single copy mutation will give you thin basement membrane disease. If, however, you have homozygous mutations at either of these loci, or two different heterozygous mutations that interact with each other, then you can wind up with an Alport's-like phenotype that starts as hematuria but eventually develops proteinuria and kidney disease. Okay, so shifting from hematuria to proteinuria, I want to first describe how proteinuria happens. You have your glomerulus in the kidney. There's the vascular pole where the blood comes in, and there's the urinary pole where the filtrate exits into the tubule. And in this schematic, I'm using blue triangles to represent protein in the bloodstream. And here it is in the bloodstream and not passing into the urine. Whereas when you have proteinuria, in an oversimplification, the urine drains along with the filtrate into the urine sample. So this is an electron micrograph of a glomerulus, and here are the blood vessels entering and leaving, and you can see the outer loops here. And this is a cross-section cutting into one of the loops. You can see that the lining epithelium is highly specialized, and a closer-up view shows you these are the endothelial fenestrations. So the lining endothelium is highly specialized, and these are the endothelial fenestrations through which proteins can sometimes pass. And then this is a close-up of the outside of one of the loops, and you can make out the epithelial processes of the podocytes, and these foot processes form smaller and smaller interdigitating processes. And so together, these are the layers that form the filtration barrier at the glomerulus. So you have your capillary lumen, and the lining is the endothelial lining shown in yellow with the fenestrations that fluid can pass through fairly freely, and molecules in cells as well. But then they hit this blue layer, which is the glomerular basement membrane that we just talked about, that is type 4 collagens. And then they hit the podocyte layer, shown here in orange, with the interdigitating foot processes. And to get another idea of it, here's a cross-section, a different electron micrograph. This is the capillary blood space, the endothelial layer with the fenestrations. The ribbon is the glomerular basement membrane, and again, in cross-section, you have foot processes interdigitating and arcading off of different podocytes. And here's a close-up view of it. And so again, the endothelium in yellow, and in blue, I'm highlighting the GBM, the glomerular basement membrane, and then the podocytes in orange. And the actual place that is the barrier to protein processing, to protein traveling or transmission across the filter, is the slit diaphragm. And you can just make it out as these small little lines in between the foot processes. Now, this is a very complicated protein structure, and another form of electron microscopy shows you the interdigitating foot processes in a different view, and you can almost see these zipper-like structures that are holding the two foot processes together. And those zipper-like structures are made up of repeats of a protein called nephrin. And the nephrin proteins in pink are inserted in the plasma membrane of one foot process, and the ones in purple are in the other, and they interdigitate and form this zipper-like structure that you can see here. And nephrin, encoded by the gene NPHS1, is responsible for maintaining the barrier against the protein, the slit diaphragm. And in nephrin deficiency, you have congenital nephrotic syndrome of the Finnish type, which is complete absence of the nephrin protein and complete loss of the foot process architecture. Here you see a foot process layer that has no podocyte, has a podocyte layer that has no foot processes at all, but an otherwise intact GBM beneath it. All right, nephrin and congenital nephrotic syndrome happen to be extremely rare genetic disorders. This disease presents in infancy, and it presents with massive proteinuria, and it's managed with supportive care, medical and/or surgical nephrectomy as much as possible. You give nephrotoxins to reduce the GFR and to reduce the protein leak, and if need be, you actually remove the kidney and maintain the child on dialysis until he's big enough to undergo transplant. This is the nephrotic syndrome of infancy. So what is nephrotic syndrome? What is proteinuria anyway? Well, it turns out that everyone has protein in the urine to some extent, and a normal range of proteinuria is less than 200 mg per meter squared per day. And that protein is composed primarily of serum proteins, the albumin, immunoglobulins, transferrins, and so on. But there's also a significant component of Tam-Horsfol protein, which is made in the renal tubule by the tubular epithelial cells. Increased levels of proteinuria would range 200 to 600 mg per meter squared per day. If you had a patient with that amount, it's elevated, it's worth assessing for other risk factors, comorbidities, and so on, and you follow that. It doesn't require intervention, but it's not quite right, and you need to figure out what's going on, and it may take time to evolve. If you have 600 milligrams per meter squared up to a gram a day, then you might consider intervention. Whether that's going to include biopsy or not depends on what else is going on. And then if you have more than 1,000 mg per meter squared per day, and strictly speaking in pediatrics, another way to think about it is more than 40 mg per meter squared per hour, which calculates out to 960, that's considered nephrotic range proteinuria. How do you measure How do you measure protein in the urine? There's a couple different ways. If you have massive proteinuria, the patient may know it or the parent may know it, that the urine itself is foamy. There's a qualitative appearance to it, and the urine can foam, especially in high streams. The semi-quantitative way is the dipstick, and the dipstick reagent is a tetrabromophenols blue, and it responds and binds to protein amino acid groups, but it also can have a lot of false positives, and concentrated urine will give you a false positive. Alkaline urine will give you a false positive. and other problems with a urine analysis can give you a false positive. So the gold standard is going to be a quantitative measurement of urine protein, where the dipstick is just a screening tool. The quantitative measurement can be done in one of two ways. It used to be that a 24-hour urine collection was imperative, and it's not necessarily true anymore. It turns out spot specimens can be used to measure and estimate protein because it's been validated that total protein excretion measured in grams per meter squared per 24 hours compared to a random urine protein to creatinine ratio, when you're measuring mgs per deciliter, is essentially similar, so that a gram of urine, a gram of protein in urine in a 24-hour collection ends up being about the same as a urine protein to creatinine ratio of 1, and a urine protein creatinine ratio of 0.1 ends up being the same as 100 milligrams per meter squared per 24 hours. So you can do it either way. And the timed collections have the advantage of being thorough, and less of an estimate, but they have some problems. They require, first of all, very clear instructions, and it requires the cooperation of the person who's providing the urine or an indwelling catheter. So it's not terribly easy. The advantage of that is, however, if you can get one, is that you can verify the accuracy of the collection. The normal urine creatinine excretion is fairly constant in any given individual of any given muscle mass, and it is in the range of 15 to 20 mg per kg for 24 hours. It's higher in very muscular people, it's lower in very slim people. But in general, you can check a 24-hour urine collection to see if the creatinine amount is compatible with this, and then you know it's a good collection or not, and the protein amount is then reliable or not, and you can modify it accordingly if you need to mathematically. The spot specimen is much easier, obviously. You have a sample of urine in a cup, you measure the protein and the creatinine, and just like for calcium and creatinine, for protein and creatinine, you want your ratio to be less than 0.2, and that is when your units are the same. They're lined up, milligrams per deciliter and milligrams per deciliter. If you have a random urine protein creatinine ratio that is greater than 2, then again, you want to check that your units are right, and you also want to then verify. You've done a random sample. Now the time is to repeat in a first morning urine sample. And so why does it have to be a first morning? Well, the point is that urine protein varies through the course of the day and with different kinds of activity. And if you have elevated protein transiently and it comes back to normal, that's considered benign. So urine protein will increase with exercise, it'll increase with stress, physical stress, and emotional and psychological stress. It'll increase with fever and illness. And as long as it keeps coming back down to normal, then it's considered benign proteinuria, and the most common kind is benign orthostatic proteinuria or benign positional proteinuria. And it turns out that this proteinuria accounts for at least half, if not more, of proteinuria in pediatric cases. It occurs mostly in adolescence. It can start in late school age as well. And it seems to be mediated by hemodynamic changes, which is why it increases when blood flow increases. You cannot diagnose benign orthostatic proteinuria if other findings or risk factors are present, so it, in a way, is a diagnosis of exclusion. This is in contrast to fixed proteinuria, where that first morning protein is also elevated. That urine protein to creatinine ratio is also greater than 0.2. It may be less than the daytime value, but if it's still greater than 0.2, then it's elevated. And this is considered fixed proteinuria. It's present all the time, and that's usually pathologic. So what's the problem with proteinuria? Well, the most common situation is nephrotic. In pediatrics, the most common situation is nephrotic syndrome. And the pathophysiology of nephrotic syndrome begins with the proteinuria. And we saw some pictures earlier of the glomerular basement membrane and slit membrane that stopped the protein from passing through the glomerular filter, and then when you have foot process effacement, the protein passes through. That protein leak eventually gets so bad that you lose ground in the bloodstream and you have hypoalbuminemia. In response to that protein leak and the hypoalbuminemia, there's a theory, and it's not entirely substantiated, is that there's an increased synthetic activity in the liver to compensate for this protein loss. And so it's trying to keep up with the albumin, but it also is making other proteins, including lipid proteins, and you wind up with hyperlipidemia. And you can have cholesterol levels in the hundreds easily in a nephrotic patient. When you have the hypoalbuminemia, you also decrease your oncotic pressure and you develop edema. That edema causes, of course, intravascular depletion because the fluid is leaking from the blood space into the tissues. And with that intravascular depletion, you're then essentially hypovolemic with decreased flow to the kidney. The kidney enters a high renin, high ADH state, and then you have salt and fluid retention. You can develop hypertension. And then, of course, you're also very thirsty, and you want to drink more fluid. But that fluid leaks into the tissues out of the blood space. And so you have, again, further worsening of your edema, ongoing intravascular depletion, and the spiral just goes round and round and round. So other complications in nephrotic syndrome are related to the other proteins that are mismanaged, if you will, not just the albumin. All proteins the size of albumin or smaller leak through the kidney. And one of the ones that leaks is antithrombin 3, which is approximately the same size as albumin. And not only do you have hypoalbuminemia, but you also have deficiency of all other small molecules. And not only do you have hyperlipidemia, but you have enhanced hepatic synthesis of other molecules that it makes normally, fibrinogen, clotting factors, clotting regulators. And this whole combination of disarrayed proteins generally leads to a coagulopathic state. Furthermore, now that you have your edema and your intravascular depletion, you have hemoconcentration and you have hyperviscosity, and you are then prone to thromboembolic events. And it turns out that clinically evident thromboembolic events, including a pulmonary embolus, a stroke, deep vein thromboses, occur in up to 10% of children with nephrotic syndrome. And then clinically silent events actually occur in a majority of children, and changes can be found on lung scintigraphy in up to 70% of kids who have no prior history of a known pulmonary embolism or event. So nephrotic syndrome in pediatrics, 1 in 6,000 children have it. 80% of these kids are less than 6, and it's more common in young boys than in young girls. Most of the kids who have nephrotic syndrome have minimal change nephrotic syndrome, and they usually outgrow their nephrotic syndrome without long-term chronic kidney disease. 10% of children who have nephrotic syndrome don't have minimal change, but have focal segmental glomerulosclerosis, FSGS. And these children do develop chronic kidney disease, and in some cases that will progress to end-stage renal disease requiring renal replacement therapy. And then the remaining 10% of nephrotic kids have something other than minimal change disease or FSGS. And they often will tend to have some chronic kidney disease, and depending on the actual etiology of their proteinuria and the associated problems, they will have variable progression to end stage. For the younger nephrotic kids, the typical 5-year-old kid who shows up in full-blown nephrotic syndrome, the diagnosis of the disease and the treatment of the disease are rolled into one. So you identify a child who has nephrotic syndrome. They have proteinuria, they have hypoalbuminemia, they have hyperlipidemia, and they have edema. And then because you're about to give a long-term course of steroids, we routinely place a PPD. And when they're cleared, we begin the steroids. While you're waiting for the steroids to work, which means through mechanisms poorly understood, is to stop the protein leak and reverse the entire pathology process, While you're waiting for the steroids to work, you implement a salt restriction and a fluid restriction to minimize the hypertension and the edema. And if they need it, you give intravenous albumin and furosemide infusions to help medical diuresis. This will minimize or reverse problems with pulmonary edema, with ascites, with genital edema, and so on, that can make people very uncomfortable. And then you simply wait and you assess the child's response to the steroids. The average child was going to respond within a week or two, and a full trial takes 2 months. If the child responds, then you deduce that they probably have minimal change nephrotic syndrome. And if they don't respond, it's more likely that they have FSGS. And these are tendencies. It's not written in stone. A non-responder or an incomplete responder is likely to get a renal biopsy to actually determine what the diagnosis is and to guide further management. 90% of kids who have minimal change nephrotic syndrome are going to respond. They may not be able to get off steroids, but they're going to respond to steroids. And 30% of kids with FSGS are going to respond to steroids. The non-responders, as I said, and the partial responders are usually going to be biopsied. And there's a slightly different approach if you're not talking about a young child. If you're talking about an older child, you're more likely to biopsy earlier than giving a full 8-week trial of steroids, especially if there's associated hematuria, because FSGS and other diagnoses are far more likely than minimal change nephrotic syndrome in an older child, and those tend to require chronic immunotherapy interventions. Okay, to recap, the minimal change nephrotic syndrome, 20% of those children who present the first time are never going to relapse again. Almost half of them are going to relapse, and they may relapse fairly frequently. A third of them may end up being steroid dependent, that if you withdraw the steroids, they will relapse then, and if you give them the steroids back again, they will respond again. And 10% won't respond to steroids at all. Those are steroid resistant. So these are different ways to categorize your nephrotic child. The cause of minimal change nephrotic syndrome is poorly understood. It's thought that immune mechanisms are playing a role because immunosuppressants clearly reverse it. And triggers of a nephrotic presentation or relapse include immunostimulatory things like infections and allergic reactions, as well as physical stress. Focal segmental glomerulosclerosis can be divided into a couple of different categories as well. There's the primary idiopathic, which is poorly understood, and it's thought to be due to a circulating permeability factor that is itself poorly understood. And this disease will often recur in a transplanted kidney. Primary FSGS that is genetic in origin, there are multiple genetic associations that have been identified. And this actually has a good prognostic indicator because while chronic kidney disease is inevitable in most cases, transplant is usually curative. The disease will not occur. And then there's secondary FSGS, which is due to immune-mediated side effects of various infections and toxins or recurrent injury to the kidneys. Okay, so now we want to tie it both together, the hematuria and the proteinuria together. You do a urine analysis, you have heme, and you have protein. In all likelihood, you're going to have casts in that sample as well. And what is a cast? A cast is based on the production of TAM-Horsfeld proteins in the tubule. As I mentioned earlier, here's a schematic of blood entering the glomerulus and leaving again. This is Bowman's capsule. The urine passes down the proximal tubule through the loop of Henle, and the green represents the secretion of TAM-Horsfeld protein from the epithelium in the tubule. And here we have a conglomeration of that protein, and once it washes out again, you will have what we call a hyaline cast. And all folks have hyaline casts. These are considered normal findings in a urine sample, and they come and go with hydration status. However, if you have any other cast in your urine other than hyaline, there is a concern for nephritis of some kind or another. Red blood cell casts are glomerulonephritis. White blood cell casts might be GN or interstitial nephritis. Epithelial casts, mixed cell casts, coarse and fine granular, and so on. So here's an example where now, in addition to the protein being made by the tubule, you have blood leaking from the glomerulus, so the red and the green come together, and you have a red cell cast where the red cells are embedded in the matrix of the hyaline cast. And if you see a red cell cast in the urine, that is glomerulonephritis. And that's a diagnostic finding of glomerulonephritis. So what's the most common kind of glomerulonephritis in pediatrics? What would be your differential diagnosis? Well, there's two things on the list. There's post-infectious GN and there's IgA nephropathy. And in most cases, it would be up to the caretaker to decide to distinguish between these two, partly because the prognosis is very different. Post-infectious GN is something where complement levels are low, hypocomplementemic, and it's complement C3. IgA nephropathy is a GN where complement levels are normal, is normal complementemic. And this is the main blood test that's going to help you decide which one is which in the presence of hematuria and proteinuria if you're playing the odds. The other part of your history is going to help you sort out which one is which. Post-infectious GN usually comes after an infection. You might consider it post-pharyngitic if your infection was pharyngitis and it was 10 days earlier, 2 weeks earlier. IgA nephropathy is often triggered by an infection. It's synpharyngitic. It's the same time as your pharyngitis. So if you're considering post-infectious GN, all patients have low C3 levels. If the C3 level is normal, then the patient does not have post-infectious GN. The C3 level is low for a good month or two, and if it's lower for longer than that and it's simply not returning to normal, then it's not post-infectious GN either, and it's a different hypocomplementemic GN. The most common or the most well-known form of post-infectious GN is post-strep GN, and the most common strep would be group A strep. And in this setting, 100% of those patients have hematuria, microscopic or macro. It's usually the macroscopic ones who come to attention. 50% of the patients have proteinuria. 20% of them actually have full-blown nephrotic syndrome. And 5% are going to have elevated creatinine with kidney injury. The good news about post-infectious GN is that it resolves completely and spontaneously without medical intervention, just supportive care, except perhaps for the hypertension, and if they have it. And the patient themselves feels better within 1 or 2 months. However, you can have asymptomatic hematuria and proteinuria persisting in the urine analysis for as long as 1 or 2 years. If you have a little child, a young child with low C3 levels, and they have hematuria, it's almost always post-infectious GN. You don't usually have to think about anything else because other things would be quite rare. If the C3, however, doesn't come back to normal, then you need to think about MPGN type 2. If your C3 is actually normal but your C4 is low, then you have to think about MPGN type 1. And this is sort of a little trick in lab testing. You should, even though you're just looking for C3, you should send C3 and C4 because you would expect C3 to be low and C4 to be normal or vice versa most of the time. And if they're both low, either you have lupus, which you're never going to have in a young child, or there was a lab error and you need to repeat everything. So sending the C4 along with the C3 works to be a nice internal control for the sample having been handled properly and no technical errors. The other alternative diagnosis that's going to be most common is IgA nephropathy. As we said, that's complement levels are normal. It's usually associated with an infectious trigger or an immune stimulation, and it can mimic post-infectious GN. And it can go away when the trigger passes. It's limited to the kidney, and it's a chronic disease, although the hematuria and the proteinuria can come and go. Some patients have hematuria only, some patients have proteinuria only, some have a variety of both. A third of them have findings that come and go and don't have any trouble. A third of them actually have some chronic kidney disease that needs more attention, and a third of them can have severe disease that progresses to end stage. In contrast to IgA nephropathy, which is limited to the kidney, HSP is a multi-organ disease whose kidney manifestations are almost identical to IgA nephropathy. The histology is the same, and the behavior during the acute episode is the same. The difference is that HSP is transient. Once you have your episodes, it generally subsides and doesn't recur at all, as opposed to the IgA nephropathy, which can continue on and off with flares and remissions for a lifetime. And then another common nephropathy that has hematuria and proteinuria doesn't quite count as a glomerulonephritis, but I thought I wanted to include it for the sake of completeness, is hemolytic uremic syndrome, where clinically a patient is going to have oligoanuria very frequently as their presenting finding, and sometimes hypertension. You will find hematuria and proteinuria in the urine, and when you screen the blood, there will be anemia, there will be thrombocytopenia, and there will be uremia. And for HUS, there is a sort of traditional way to think of the two different categories of HUS, D plus and D minus. D plus is a diarrheal disease. The classic agent that causes it is E. coli 0157H7. That's a typo. And it produces a Shiga-like toxin, which is responsible for the pathology. And it is an acute disease that does not recur. And if the patient gets enough support and can survive the acute insults, they will recover, maybe with residual chronic kidney disease, maybe not. On rare circumstances, you can go on to complete renal failure, but that's not the most common. D minus is a different kind. This is no diarrheal prodrome. It's considered atypical HUS. It is often familial. You may be able to elicit a family history, but often not. And it is mediated by problems in the regulation of the alternate pathway of the complement system. And you will have abnormal regulation of complement C3. You will have consumption of complement C3. And it is usually related to gene defects in one of the complement proteins, either C3 itself or some of the regulators or cofactors of the complement cascade. In this situation, if that first episode is not catastrophic and doesn't shut down your kidneys, you can have episodic flares that occur chronically, and eventually you will progress to end-stage disease. And so here we are recapping. Summary for hematuria alone. We talked about the assessment of microscopic or macroscopic hematuria being very, very similar, and there's no good reason to distinguish between the two in terms of etiology because there's no gold standard there. The assessment is going to include sending a urine culture, sending a protein creatinine ratio, a calcium creatinine ratio, and having a very low threshold to get a renal ultrasound. Another thing we discussed is that persistent, otherwise asymptomatic microhematuria is most commonly caused either by hypercalciuria, IgA nephropathy, or thin basement membrane disease, and they don't necessarily progress. We talked about proteinuria. We discussed that the spot urine protein creatinine ratio is generally a reliable reflection of a 24-hour protein collection and is a lot easier to do. We discussed that it's important to assess the first morning protein creatinine ratio compared to one later in the day, and to distinguish between fixed proteinuria and orthostatic proteinuria, which is probably the most common cause of proteinuria in adolescents at any rate. Pediatric proteinuria that's elevated and abnormal is commonly caused by minimal change nephrotic syndrome, which is transient, which folks outgrow, and that the nephrotic children are hypercoagulable. So in the world of pediatrics, if a child is going to have a stroke or a pulmonary embolus, it's going to be a nephrotic child. Hematuria and proteinuria together have a worse prognosis than either one alone, and if they are present in the setting of a chronic disease, are going to lead to chronic kidney disease to some extent or another. And post-infectious GN and IgA nephropathy, post-infectious being post-pharyngitic with low complement levels, IgA nephropathy or synpharyngitic with normal complement levels. These two are the most common causes of acute GN in pediatrics.